Good morning. Thanks to everybody for coming. I'm going to be talking about colorectal cancer screening overall. And as you'll see, there's some very important changes in colorectal cancer screening that I think are of great relevance to folks who are attending this conference. So I'm going to be talking about the challenges associated with screening, reviewing recent updates to the U.S. Preventive Services Task Force that have a lot of implications for health plans and providers. Talk about some of the evidence that led to those changes, discuss the implications for increasing screening participation, and then some strategies to use to help with adoption of USPSTF. So colorectal cancer is the second most common cancer killer in the United States when you look at men and women combined. 53,000 men and women are going to die of this disease this year. And that's particularly concerning when you recognize colorectal cancer is one of the few cancers for which we actually have a preventative element. When we screen for breast cancer, we don't prevent breast cancer. We screen for prostate cancer, we don't prevent anything. We can prevent this cancer with the screening tests that we use, but we're just not doing it effectively. If we even miss that prevention opportunity, then finding the disease early makes a huge difference. Precancerous lesions, polyps, adenomas, take a long time to transition to cancer. So it's usually about a 10-year window between the development of that polyp and that polyp becoming cancerous. During that 10 years, if we find and remove it, we prevent disease. But if we miss that 10-year window, but we find that cancer early, it still makes a huge difference in outcomes. Cancers found in the earliest stages, 9 out of 10 of those people are going to be alive 5 years later. 90% 5-year survival. On the other hand, if it has metastasized by the time we find it, only about 1 out of 10 of those people are going to be alive 5 years later. So a huge difference in outcomes made by screening. This study from Kaiser looked at a number of patients in their system who died from colorectal cancer and found that 76% of the individuals who died during the study period from colorectal cancer had not been screened. They weren't up to date with screening. So huge missed opportunity. Colorectal cancer incidence and mortality is not spread equally. Now, everyone is at risk, but for reasons that remain unclear, African Americans and Native Americans and Alaska Natives have higher incidence rates and higher mortality rates. The mortality rates are felt to be at least in part related to access to care and the quality of care provided. The incidence rates, we really don't have a good answer for why those differences exist, but they're well documented. Now, hopefully some of you are familiar with a goal that was set by the National Colorectal Cancer Roundtable back in 2013. They established a goal of the nation achieving 80% screening rate by 2018. So 80 by 2018 was a large national campaign that involved the National Colorectal Cancer Roundtable as the leader, but the Centers for Disease Control, the American Cancer Society, state and local health departments around the country, all the major GI organizations. And during that period, there was a rise, but colorectal cancer screening rates are here, this lowest line. You can see back in the early 2000s, we were just over 40%, and that has continued to rise, but it's still well below breast cancer screening and cervical cancer screening. So we have a long way to go. We did not hit that 80% goal, at least as a nation, although there were a number of health systems, a number of states actually that came very close to hitting that 80% goal. But at the time of the last data collection, we're still looking at about 1 out of 3 individuals who should have been up to date with screening who were not screened. And things have changed since then, as I'll be talking about. If we look across the country, significant variation from state to state, from region to region. And unfortunately, Texas is bringing up the rear. Oh, wow, that's a bad colorectal cancer joke.
Are we surprised?
So in the Northeast, those states, 75, 76, 77% screening rates for the entire state. Out West, low 70s. Texas, Nevada, Wyoming at 58%, so at least there's one state that's worse than us. But in general, we're not doing a really good job. We're not doing a great job. So again, as of this data collection, which was 2018, and that's very important, we were at 67%. I'll be talking about a little more recent data. Again, looking specifically at Texas, even though our rates are low, if you look at specific subgroups, rates are even lower. So individuals with low educational level, individuals who have lower income, and in particular, if you're uninsured, your likelihood of being up to date with screening is less than half that of the general population and the insured population. So let's talk about the USPSTF. The U.S. Preventive Services Task Force is a quasi-governmental. They're pulled together by the federal government, but it's actually a group of volunteers. These are volunteers in primary care, epidemiology, and public health who come together and create guidance for the nation around a wide variety of preventive services. Their work, they've been around for 30 years, I believe, but their work took on an extremely important element when the Affordable Care Act was passed, because the Affordable Care Act requires that any service, any preventive services recommended by the U.S. Preventive Services Task Force with either an A or B recommendation has to be covered with no out-of-pocket cost within most health plans, not all, but most health plans. And A or B basically means, A means that the service is routinely recommended, there's a very high certainty of benefit, so everybody should get that. B means the task force still recommends that service. The evidence is not quite as strong as it is for an A recommendation, but they still recommend that everyone in that category get that service. C recommendation means it should be offered selectively, so there are some folks for whom it may be helpful, others for whom it may not be particularly helpful. Then there's I, which is there's insufficient evidence for or against, and then D, which is don't do it. But colorectal cancer screening is an A and B recommended service. The task force updated their guideline earlier this year. May of 2021, they released a new guideline. And that guideline stayed with the script with regard to the 50 to 75-year-old age group. A high certainty of net benefit, therefore a grade A recommendation. Now, going all the way back to 2020, to 2000, I believe, was the first time the task force recommended colorectal cancer screening as a or B rated service. And every organization since at least 2000 has recommended screening begin at age 50 for everyone. However, for individuals 45 to 49, this was a huge change for the task force. And as you see, it's a B recommendation. Doesn't mean it's not good evidence. It means the evidence is not as strong as that for the 50 to 59-year-old population. But if you think about it, we've only been screening people over the age of 50. Therefore, the evidence base for screening earlier is fairly thin, but it is rapidly growing. So their recommendation really push the medical community, because if the task force says do it, you can be comfortable that there's a pretty significant body of evidence behind it. Actually, they were a little late to the party. The ACS back in 2018 recommended screening starting at age 45. And then a number of other organizations this year also are aligned with the task force. So essentially every major medical organization now recommends screening for colorectal cancer starting at age 45 for all men and women, regardless of race, gender, ethnicity, etc. The other thing that all the guidelines say is patients should be aware that there are tests other than colonoscopy. Unfortunately, if you talk to patients and ask them about colorectal cancer screening, those patients who have not been screened, by and large say, I didn't want a colonoscopy, or I don't have access to colonoscopy. Because when patients think of screening, they think of colonoscopy. The fact that there are a wide range of other tests, actually, that are called out in the task force guidelines here. There are stool-based tests, 3 different ones. There are direct visualization exams, again, 3 different ones. And all of these organizations offer some permutation of that same menu of options. So all of the major medical groups now say it's not enough to tell patients they need to get screened. You need to let them know that there are options other than colonoscopy, and that's how you increase screening rates. There's actually a growing body of evidence demonstrating that if you really want to improve screening at a population level, you have to offer options, because not everybody is going to get a colonoscopy for one reason or another. Now, one of the things that has been an impediment to people exercising those options is many health plans have interpreted the guidance in the ACA to mean that whatever the first test that's done is the test that gets covered with no out-of-pocket costs. So if a patient chooses a $25 FIT test as their initial screening test for colorectal cancer, in many instances, if that test is positive, that patient now has to have a follow-up colonoscopy. That is in every guideline, every organization. However, in many instances, that follow-up colonoscopy is not viewed as a continuation of the screening process. It is interpreted as, oh, well, now it is a diagnostic test. Across the colorectal cancer community, all of the major medical organizations, the GI organizations, everyone is aligned that, no, this is a continuation of the screening process. If a patient has a positive stool test, we know that those are individuals who are now more likely to have a significant adenoma or a cancer, yet we're putting financial barriers in the way of that being done. Now, Texas actually has stepped out. You heard yesterday about surprise billing. This is another element of surprise billing where patients would get a stool test, it would be positive, and then when they went to get a colonoscopy, they would be informed, oh, if you get this colonoscopy now, it may cost you $300, $400, $500, $600 because it's no longer considered screening. The Texas legislature actually took this issue in hand and now requires that a continuation of the screening process, like a follow-up colonoscopy for a positive stool test, is covered with no copay and no deductible. And that starts as of the upcoming plan year. Now, why have all these organizations decided that 45 is the new 50? Well, it's because of evidence like we see here. This top graph shows colorectal cancer incidence trends over the last 3-4 decades. And as you can see, starting in the late 80s, early 90s, for both men and women, there's been a steady downward trend in colorectal cancer incidence. And that is felt to be in large part due to screening in that population. But that's for people 50 and older. Look at the bottom graph. For individuals between the ages of 20 and 49, over a similar time period, you see a steady uptick in colorectal cancer incidence in this younger population. And that uptick actually amounts to a 51% increase in the incidence of colorectal cancer in individuals under the age of 50 over just a couple of decades. That means that now more than 10%, more than 1 out of every 10 cases of colorectal cancer diagnosed in the US are occurring in people under the age of 50, under the age where screening traditionally started. And we also know that individuals who were diagnosed before age 50 have a greater likelihood of having more advanced disease. 52% of those individuals are going to have stage 3 or stage 4 cancer at the time of diagnosis, compared to only about 40% of people over age 50 having advanced disease. So for all of those reasons, and just a tremendous body of evidence that's been developed around this, all these organizations are certain that we can make a difference, can make a dent in this shift by starting to screen people earlier. This is evidence that was developed by the Preventive Services Task Force in looking at the impact of different types of screening for individuals. The blue bar is starting screening at age 50, and whether you start with every year FIT, stool DNA every 3 years, colonoscopy every 10 years, you can see in that column to the left a significant number of life years gained per 1,000 individuals screened, regardless of what screening modality is chosen. And then the orange bars at the end there That's what happens if you shift to start screening instead of 50 at age 45. That is the additional life years gained. So by screening individuals, again, regardless of methodology, by screening people earlier, we add more life years. So again, a lot of evidence was developed by the task force, a lot of evidence was winnowed through, and there is a high level of comfort that we can do good things by starting screening at 45 instead of 50. This is Texas-specific data. And you can see on the left, those are incidence trends. And you can see that for the US and for Texas, colorectal cancer diagnosis under 50 has been steadily rising, again, for more than 2 decades. On your right, you can see that colorectal cancer mortality under age 50 also has steadily risen, not only in the US, but in Texas. This is the Texas line, and it's actually rising faster than the overall US rate. And again, all the numbers I've been sharing with you, particularly around screening, are pre-COVID numbers. We know that COVID decimated our healthcare system and led to tremendous challenges and disruption, particularly in cancer screening. So before COVID, we had low rates of screening, and then as to the question that was raised earlier, in addition to income and education, we also see differences by race and ethnicity, we see differences by immigration status, and who was most negatively impacted by COVID. Many of these same populations who already were underscreened. If you look at the impact of COVID, those are the same communities that were over-affected. And we know that there was a tremendous drop-off in cancer screening, particularly early in the pandemic. This is data just from January through July of 2020, so at the beginning of the epidemic. And we saw such a dramatic fall. That blue line is colorectal cancer screening. It fell off the map. And it began to climb and improve, but notice even by June and July of 2020, it was not back to normal. There was the expectation that, okay, well, we're done with the worst of it. But we know since June 2020, we've had continual issues and intermittent disruptions due to Delta, due to a variety of other issues. So in a lot of places around the country, there still is not the same capacity for colorectal cancer screening that there was in the pre-COVID era. And even in those places that have recovered, this is an estimated 4 million missed colorectal cancer screenings just during that narrow period of time. So the number of missed screenings is likely much larger. So not only are we trying to get people up to date with screening, but we're also now trying to go back and find those folks whose screenings were missed. And there is significant concern that because of those missed and delayed screenings, we're going to end up seeing more cancers in the future. And those cancers are going to be more advanced because people didn't get screened, those cancers didn't get caught early. And again, in the early phases of the epidemic, we saw a dramatic fall in cancer diagnosis. Now, there's no reason to think that those trends that have been steady for many, many years suddenly got better because of COVID. We just missed those cancers. And we will be finding them, but in many instances, we may be finding them at periods that are too late to intervene effectively. So we need to be doing everything that we can within the systems we're working to make sure we're using every tool in our toolbox to address the backlog and to get folks screened who are not up to date with screening. And on top of that, we've added in this new 45 to 49-year-old age group. It's estimated 19 million additional people are included in that age group who now need to be screened. So we were at 67% missing 1 out of 3 people when we were only trying to screen over age 50. So our screening rate is going to go down precipitously. So we have this trifecta of pressures. We've got the expanded screening population, 45 to 49. We've got the impact of COVID and the disruptions. And then we already had disparities within the screening spectrum in the US and those disparities are likely going to be exacerbated by all that's come so far. So this is where we really see Cologuard offering tremendous opportunity. Their mtsDNA, let me tell you a little bit about what Cologuard is. It's intended for the qualitative detection of mutations, DNA mutations, or other biomarker mutations that are associated with colorectal cancer. It is, or with advanced adenomas, which is an important point. It's indicated as a screening test for individuals age 45 and older. We actually have an indication from the FDA for screening at age 45, which none of the other tests out there can say. It is not a replacement for colonoscopy. So if an individual has an abnormal finding on Cologuard, they need a follow-up colonoscopy. If they have an abnormal finding on some other screening test, you can't use Cologuard in that instance. It is for average risk individuals who have no signs or symptoms of colorectal cancer. So it's contraindicated in people under the age of 45, contraindicated in people who are known to be at high risk, such as a personal history of colorectal cancer or adenomas, or a family history of colorectal cancer or adenomas, or patients who've been diagnosed with conditions like Lynch syndrome, or diagnosed with inflammatory bowel disease or other conditions that put them at increased risk. So it is for average risk. The other thing to recognize is that the performance of Cologuard has been studied in a cross-sectional fashion. That is a point-in-time study. So the programmatic performance of Cologuard over an extended period of time is currently under study, but we don't have data on that. So the data I'm going to share with you is based on cross-sectional studies that we've performed. The clinical validation study that I'll be going into some detail about was performed largely in the 50-plus population, and therefore estimates about its impact in 45 to 49-year-olds is largely based on assessment of near age groups, but we have developed some additional research specifically in that group. Colorectal screening recommendations in individuals over 75 should be individualized, and that includes whether or not to use Cologuard, as it does for all other colorectal cancer screening methodologies. Cologuard specificity actually falls in advanced age groups. So it's important to keep that in mind when you're considering screening for older populations. A negative Cologuard does not guarantee that cancer or adenomas are not present, just as a positive Cologuard does not guarantee that there is cancer or a polyp present. So every positive needs to be followed with colonoscopy. Every negative, patients need to be informed that if they develop any new symptoms or issues, that they need to get reassessed by their provider. Patients also should not collect a sample for Cologuard if they are actively bleeding, if they've got blood in their stool or urine, as that can bias the results. And our lab has to receive the sample within 72 hours of collection. And we've put processes in place to make that very feasible and doable for most patients. And patients should be cautioned not to drink the preservative liquid that's included in the package that needs to be poured into the stool specimen, should not be taken internally. And also need to be cautioned to be careful when opening the boxes so they don't strain their hands. Hey, this is the FDA, not me. So how does it work? mtsDNA, multi-target stool DNA testing, better known as Cologuard, is based on the fact that blood is the primary marker used in other stool tests. And bleeding is intermittent in many instances. Bleeding requires a certain size lesion. It requires that there be disruption of the blood vessel wall to allow blood to leak into the stool. So larger lesions bleed, smaller lesions not so much. And not every cancer, not every polyp is going to bleed, but some do, enough that stool testing for blood can be impactful. However, DNA biomarkers are continually shed into the stool. They don't require disruption of blood vessels. They're coming off of the lining of the colon as it is sloughed, and some of that is included in every stool specimen that you get. Cologuard looks for 10 different DNA biomarkers and for a blood-based biomarker as well. So you're looking at the results of 11 different biomarkers when you get a Cologuard test. The largest study to date that has looked at the performance of Cologuard was designed, number one, just to determine how well Cologuard did finding cancer. That was the primary outcome. And then the secondary outcomes were how well does Cologuard detect advanced precancerous lesions, those kind of cancer, polyps that can progress to cancer, and how well did Cologuard perform when compared with a high-quality FIT test. So this study enrolled over 10,000 people. And the final analysis was done on, I believe, 9,989 individuals. And those were folks who collected a specimen for Cologuard, collected a specimen for FIT, and underwent a screening colonoscopy. So these were all asymptomatic average risk individuals. And what they found was, among patients who had cancer, found at that colonoscopy, Cologuard detected 92% of those cancers. That compares with just under 74% of those cancers that were detected by FIT testing. And then looking at advanced adenomas, Cologuard found 42% of the advanced adenomas compared to just under 24% of advanced adenomas found by FIT testing. Now, with that increased sensitivity comes a lowered specificity. So there was a higher false positive rate with Cologuard. 86% if you define false positive as no cancer or no advanced adenomas. Actually, the specificity is 89.8, essentially 90% if you define a negative colonoscopy, that is no findings at colonoscopy. And also, as I said, this was a study done largely in the 50-plus population. We've subsequently developed data in the 45 to 49-year-old age group. Specificity is significantly better. It is around 95% in the 45 to 49-year-old age group. The other thing is that, remember, this is a snapshot, a single point in time. So although the specificity for Cologuard is lower, Cologuard is recommended as a once every 3-year test if it is negative. If there are no findings on Cologuard, it doesn't need to be repeated again for 3 years. FIT is an every year test. And if you do FIT 3 years in a row, one, just getting patients to come back and complete their FIT 3 years in a row is a challenge in almost every setting. And then two, the specificity over time almost levels out between FIT done 3 times and Cologuard done 1 time. So it's a little misleading to compare the specificity of FIT versus Cologuard. So when we talk about getting more people screened, there are a large number of interventions that have been demonstrated to be helpful at getting people screened. There are some folks, primarily affluent, well-educated, high-income individuals who, for the most part, are going to follow through with screening recommendations. But for much of the populace, colorectal cancer screening is just one more thing that they're being told to do. If they're not having any signs or symptoms, nobody in their family had it, they're not necessarily inclined. It's not top of mind for them. A variety of things have been shown to help move people to get screened. A lot of it being education related, some of it being reducing the cost to individual patients, but things like patient navigation, things that remove barriers, removing transportation barriers or other kinds of barriers are helpful. And then reminders, all of these have been shown to be useful. This recent study looked at the impact of a variety of different kinds of interventions and found that mailed outreach in particular, this was using mailed FIT, led to a very significant increase in colorectal screening. Also, patient navigation and patient education and reminders had lesser but still important impacts. One of the things, when you order Cologuard, one of the things to keep in mind is once that provider writes that order, it's not just the order for the test. Cologuard has a built-in patient navigation system. Number one, we contact the patient, make sure they understand that they're going to be getting this kit in the mail and what it's about. We talk to them about, our lab talks to them about why they're getting screened for colorectal cancer. Make sure we have the right address, then we send the kit out to them. And then we call and remind, we send letters and remind to get those specimens back. And we also will use text and email if the patient opts in. So we have a built-in patient navigation system that encompasses a number of the things, the kinds of interventions that have been shown to be useful at boosting colorectal cancer screening rates. And consequently, we feel that this contributes to the higher screening rates that we've seen in a number of different studies. So for instance, this study was in Medicare beneficiaries who were prescribed Cologuard. This was more than 360,000 individuals, and you can see that 71% of those individuals actually completed and returned their specimen and allowed us to give an accurate result on Cologuard testing. 71%. For those of you who have run and managed FIT programs, you're getting back 71% of those FITs. This is another study. This was a single county study looking at a Medicare population. These were individuals who had not followed through on prior screening recommendations and were given Cologuard. 88% of those individuals, again, Medicare, completed their colorectal cancer screening. And of those individuals who had a positive finding, 96% completed their follow-up colonoscopy. Again, for any of you all who are looking at follow-up colonoscopy rates in individuals who have positive FITs, your data is not likely to show a number like that. We have looked at the performance of Cologuard in minority populations. This study looked in African Americans and found no significant differences in performance in the African American population. We've also published work on the Native American and Alaska Native population. And again, the performance of Cologuard is similar across those groups that I already told you earlier have higher incidence rates and higher mortality in colorectal cancer. One of the challenges that many of us in the colorectal cancer community have with the U.S. Preventive Services Task Force is the data that they use, those estimates, like the one I showed you earlier, estimating number of life years gained, et cetera. We find those useful, but not sufficient, because the task force in all of their modeling persistently uses 100% adherence. So 100% adherence to a FIT test over a 20-year period, 100% adherence to colonoscopy, 100% adherence to follow-up colonoscopy, numbers that, quite frankly, no one has achieved. Kaiser of Northern California has probably the best colorectal cancer screening program in the world, and they get about an 80% overall screening rate. They publish their data on follow-up FIT testing, and each year, the proportion of FITs that are returned fall off. They publish data on follow-up colonoscopy, and they have admirable rates, again, close to 80%, but nobody's hitting 100%. And then you move into general practice environments, you look at other systems that have published their data, and they're far below 80%. So we worked with modelers to develop models based on the same platforms that are used by the task force, in particular CRC SPIN, and developed a modeling platform into which we can plug real-world data based on the kind of studies that I've shared with you. So as opposed to 100% FIT adherence, when we use our CRC AIM model, we use data from the literature. So FIT adherence of 43%, or guaiac fecal occult blood testing adherence of about 34%. And follow-up colonoscopy rates, again, 47% or so. That's what you find in the medical literature when you look at how many patients who had a positive FIT or a positive guaiac test actually get a colonoscopy within the next year. And then we use the real-world data for Cologuard, 71% that I just mentioned to you earlier, and then a 73% follow-up colonoscopy rate. Those sources are verified. When we put that data into the CRCA model, then we find that for Cologuard compared to FIT, whether we start at age 50 or at age 45, we get a significantly greater number of life years gained using Cologuard every 3 years, using real world data, not 100%. When we look at the number of colorectal cancer cases and deaths, well, for FIT or Cologuard, significantly fewer cases, significantly fewer deaths than the gold bars, which are no screening whatsoever. But again, Cologuard, whether we start at 50 or 45, you have reduced incidence and reduced mortality compared to FIT. So we outperform FIT in every measure. Looking specifically at the Medicare population, again, using that real world data, a significantly greater number of life years saved, lower incidence, lower colorectal cancer mortality. The previous data was for people 45 through 75. This is Medicare specific data. And you see, we again
Does it stop at 75?
Our modeling to this point only looks through age 75, because that's the guideline.
Yeah.
After 75, then there are a variety of reasons that you may want to continue screening, but there are a lot of individuals in that age group who are not likely to benefit as well. And then when we look at cost, the cost effectiveness ratios for Cologuard are strikingly better than FIT or FOBT. You get a very high level of improvement compared to the cost that you invest. So we save more lives at a socially acceptable cost. So when you compare Cologuard versus FIT, there are a lot of reasons that Cologuard really should be considered as standard of care. We reduce colorectal cancer incidence and mortality at significantly higher rates. We lead to more life years gained, and it is cost effective. And remember, we're now looking at about 44 million people in the US who are not up to date with screening. And we look at the 45 to 49-year-old age group that was just added. We look at all the individuals who previously were not up to date with screening. And this is predicated on 2018 data before the pandemic. So this is a conservative estimate of the number of folks who need to get screened. 90% survival for early stage diagnosis. And we have a very high early stage diagnosis. And in the first year of treatment, at least $50,000 less for individuals who are diagnosed with early stage versus late stage disease. So this has real financial implications as well as the human cost. And to this point, 94% of individuals who are prescribed Cologuard end up with no out-of-pocket cost. The vast majority of insurers, including Medicare, cover Cologuard. Vast majority of commercial insurers cover Cologuard. So very few patients end up with out-of-pocket cost. And we actually have sort of an ombudsman program at Exact Sciences. So individuals who may experience a bill can work with our staff to help address whatever questions are and hopefully eliminate that cost to them. Yes, sir.
So when you look at the data that you've presented so far, you have a test which is more sensitive. It has some ease issues because it's once every 3 years versus 3 years in a row for FIT. But balanced off against that, you have a somewhat higher false positive rate. The statistic that I've used a lot in my work for a long time has been the cost per true positive. Does that data exist?
It does, but I can't give you the number.
I'm curious to see that versus FIT, because for some people that is likely to be a good report. It costs you less of this stuff to find somebody who, and that's, you've got other data that says, well, even if it's not true, you really should be using the Cologuard because of the overall cost savings.
Right.
But I think that for some people that it actually costs you less to find somebody who really has the disease.
Well, the other thing that's important to keep in mind, however, is that a test is only useful if it's actually completed. And when you compare Cologuard with FIT, the likelihood that we will complete the test, that the patient actually will do the test and you will get an actionable result back, be that a positive that needs colonoscopy or be it a negative, and now you're comfortable this patient doesn't need anything for 3 years. Those are the kind of costs that sort of get buried or missed. But I think that that's a very real issue. Now, in addition to the commercial coverage I just mentioned, we now have contracts and agreements that cover 74% of the Medicaid population across the US, including Texas. So right here in Texas, Texas Medicaid covers the cost of Cologuard. Again, no out-of-pocket cost for patients. So to date, we have screened more than 6 million individuals, and in some of our data indicates that 43% of those were people who had never been screened before. So it's not that we're translating, or shifting patients from doing FIT or doing colonoscopy. We're getting patients who have previously not been up to date with screening, but are willing to do Cologuard testing.
Super interesting. As you were talking, I was looking up a lot of the regulations around like NCQA and HEDIS and MIPS, and it was kind of interesting from the 45 to 50-year-olds that a lot of the regulations are not requiring that 45 to 50-year-olds are screened.
Yet.
Okay, good. That's what I wondered, because
Yes.
I mean, unfortunately now I'm in that age group, and I'm thinking we've never received anything about colorectal screening.
Right.
And
Well,
as a clinician, I haven't heard of that. So,
yeah, most of the quality measures actually are framed around the Preventive Services Task Force. And the task force recommendation to start screening at 45 is less than 6 months old. It was May of this year. I know that NCQA, we've actually had conversation with them. They are looking at revamping their guidance. The UDS measure that's used in federally qualified health centers, they're looking at revamping that guidance. Actually, there is a Medicaid quality measure that is awaiting a final vote that is likely to go into play, and they're looking at 45 for that measure. Maybe not in the first year, again, just because of the timing of the task force recommendation, but it's coming. And I will also say that a number of health plans recognize, actually a number of health plans shifted their guidance back in 2018 when the ACS first recommended 45 plus. And a number of other plans have moved in that direction. So a lot of plans are recognizing that this is coming, whether it's mandated or not for them right now, and they're already making a move toward expanding their screening to the 45 plus population. Did I see another hand? Maybe not. All right. Yeah.
Well, how do you think we can improve screening for colorectal cancer? I mean, when you look at mammograms and PAPS tests, we've been able to almost eliminate, death to those cancers. I mean, I'm exaggerating, but we haven't seen that with colorectal cancer. What needs to change?
Well, I will say that was a long time coming. But it eventually became normalized. And I think we're coming close in colorectal cancer that people are now starting to recognize that this is something that impacts them even if they don't have any symptoms or even if they don't have any close family members. But one of the things I mentioned at the beginning is the perception that colonoscopy is the only screening test is a huge barrier. Study after study after study has shown that if you give people options and give them a stool-based option, anywhere from a quarter to half of people will choose a stool-based option over colonoscopy. But in many settings, patients are never even made aware that there are tests other than colonoscopy. So we have to get past that colonoscopy bias. And I will say that I was actually at the American College of Gastroenterology meeting 2 or 3 weeks ago. And even in that, almost all GI audience, there was a lot of discussion about the importance of options. The GIs are recognizing that you can only scope so many folks. And I think COVID also helped awaken the fact that giving people options that don't require them to come somewhere, to come and see them, because a lot of patients got hesitant about going into medical facilities, having procedures done. The fact that they can stay at home and have something shipped to them. There was a lot of talk about mailing fits, but there was also a significant conversation about Cologuard and the potential value of Cologuard in the GI audience. So I think that that will go a long way toward helping move primary care clinicians and ultimately their patients. But it takes education, it takes time and effort to talk through these things and finding ways to make it easier for primary care providers and systems to have those conversations or to get that information is another important element to that. Okay. Well, thank you all so much for coming and listening, and I'll be around for a little while if there are other questions that arise. And
Thank you so much.
at the
We
end.
appreciate